That's our program here in Alameda County. I'm titling this talk for you all, Scaling Regenerative Food as Medicine as a Health Multiplier. So food as medicine, which you all know about, regenerative is the cornerstone for what we're doing, and I'll share more. And this concept of a health multiplier, that as much as I am in the clinic seeing patients or our clinician colleagues are doing that, that there's health benefits to food as medicines constructed and built this way. I want to start with a barrier that we probably all feel and have experienced. And these are really around system silos. There's silos between food system people, there's silos between agriculture, like the people who are actually growing the food, and there's silos around health. You're going to hear me, I'm a family doc by training, and I have a fellowship in integrative medicine, but you're going to hear me talk about areas that you may not always hear doctors talking about, which is really on the food and ag side. And I don't consider myself an expert in that. I look to my farmer friends and food system folks who know and have a deeper understanding than I. But I do think that the ability to cross into other areas that are not always considered our lanes is critical to this moment, because many problems that we are all facing are not solved by departmental solutions, that they're going to require an interdisciplinary approach. And I think food as medicine is one of these approaches that can help break down the silos. I'm going to quote Wendell Berry. He's a farmer, environmentalist. People are fed by the food industry, which pays no attention to health, and are treated by the health industry, which pays no attention to food. Does that resonate with folks? Kind of just thumbs up, thumbs, like yes, kind of. At least I can say as doctors, we traditionally have not really thought much about food beyond lip service. And then I have family members who are chefs and all, and they pay attention to food and how delicious it can taste. But there's sometimes the whole food industry is kind of not always thinking about health. I want to throw in one piece that's a level lower, if you will, kind of infrastructurally below kind of this, which is I think the food and health industries don't pay attention to the land and soil. And I think there's a distinction. Soil being the beyond dirt, but it's that microbial, all that stuff, that the beautiful stuff that our food is grown in. But land is our human connection to land, sense of place, history, trauma. We may be on stolen land, etc. There's both and. But I don't think food and health usually think about this enough. And then I think the value proposition and what I'm sharing with you all that I think you all are probably doing in some capacity is that regenerative food as medicine has the power to bring these silos together. So with that, I want to start also, or I also want to share two challenges we're going to face. So this next section of what I'm going to share is the health challenge. I'm going to go through a few slides there, and then I'm going to go into the ecological challenge. So from a health perspective, there's three big challenges. There's chronic conditions, there's kind of our food environment, an unhealthy food environment, an ultra-processed food environment. 60 to 80% of our food, depending on your study, is ultra-processed in the American kind of food milieu, food environment. And then there's food insecurity. These are three challenges that our communities face. When it comes to chronic disease, this is from the CDC, if there's 10 of us in the room, 6 of us have already a chronic disease. And chronic disease, mind you, are really much more end stage: diabetes, heart attacks. This doesn't necessarily even include pre-diabetes or high blood pressure. Yet, to me, in my world, we need to go beyond just disease, and we actually have to move upstream and address some of these risk factors. Chronic disease is the leading cause of death and disability. How much do you think we spend on healthcare every year as a nation? Can folks put things in the chat? Throw out a number, or come off mute and say. And tell me, I won't be able to read the chat, so someone read it out loud if they can.
Yeah, we have trillions, 63 billion.
63 billion, higher. Trillion, how many trillion?
3
Higher.
trillion.
10 trillion.
A little lower. So right now
We had 5.
We're at 5 trillion roughly. We just spend. We just spend. That's what we spend. And 90% of that 5 trillion, 4.9 is on chronic disease. Who manages chronic disease in our country? on the healthcare side. It's primary care, family medicine, pediatrics, internal medicine, and then we have public health as well. Community health workers, there's a whole, our apparatus is not well structured to deal with this. I put this because I think we have an opportunity because I just said it's around 5 trillion, easy to remember 5 trillion. It's a lot of money being spent for all these different conditions and diseases. How much do we spend on the farm bill? Like how much does the farm bill give us every year? Farm bill is like a big, hotly debated, very political subject. Everyone's fighting over it. It informs a lot of our food and ag policy. How much is that?
2 billion,
Lower per year. Oh,
300
actually, no,
billion.
it's higher than 2 billion per year. Yeah. Keep on going. Other ideas. It's 86 billion roughly per year. So that's a lot of money. 86 billion subsidies to corn, soy, etc. But compared to 4.9 trillion, it's 2%. So healthcare is a sleeping giant. And I see doctors on the call here, folks in healthcare. We have an opportunity to awaken that sleeping giant, if you will, to use some of the funding to transform our food and health, our food and agricultural systems, or do our part to doing that towards a food and health system, food and ag system that actually benefits our health, where we grow the food that will actually help our communities, help our patients be more well. Okay, so that's one concept, one challenge. The second challenge is the unhealthy diet itself. This is actually the #1 driver of death or mortality in the US. Many people think it's smoking, which is a high driver, right? Or heart attacks and all of that. But here's the data, and here's the mechanism. An unhealthy diet, chronic disease, which we just talked about, death. And here's the stacking of the data. 25 years of data looking at dietary risks compared to tobacco, compared to high blood pressure. All of these colored boxes are associated with different types of disease. So I'm going to highlight dietary risk, and I'm going to look at all these blue boxes here. That is attributed to, in public health, we call it non-communicable diseases, which is cancer, heart attack stuff, respiratory issues. It's all the stuff that is not necessarily an infection. So it's higher than tobacco. We're losing 500,000 people a year attributed to dietary risk, which informs our chronic conditions. So there's a clear relationship between chronic conditions and the food that we take in our bodies every day. And then the third challenge is food insecurity. And in a lot of our communities here in Alameda County, we have folks who are food insecure. And a lot of them are our pediatric, our children, as well as our pregnant women. I see a lot of that in our clinics when we look at our data. And health insurance companies will tell you, yeah, that's not a condition. We can't use healthcare dollars for this. I beg to differ, and our county differs. We have chosen we've chosen that we will screen for food insecurity and treat food insecurity in a healthcare context with our Recipe4Health. Now, why? It's because if you are food insecure on this blue line, say Blanca is food insecure and Gabriel is food secure, Blanca is going to have 2 times the risk of developing diabetes compared to Gabriel, even if you both don't have any pre-diabetes, no hypertension, nothing, just purely food insecurity. So to me, this is early intervention. We see this. If Gabriel came in and didn't have any other conditions, we train our clinic staff, red alert, something is happening with Gabriel. Can we get him Recipe4Health and then sign him up for CalFresh or other programs? So that's the trifecta of 3, and I could go on, but I'm going to pause with the health challenges, and I'm going to move us into ecological challenges. So ecologically, right, our planet is on fire, and there's a relationship to farming. Here's one example. One ecological challenge is climate health and greenhouse gases. Greenhouse gases lead to global warming and a lot of the other issues. How much of greenhouse gases is attributed to agriculture and food. Does anyone have a percentage? And shout it out, or someone say something I can't see.
7%.
7%. Okay, it's higher. Good, placement. Other thoughts?
Someone put 60%, 10%.
Okay. Yeah, so it's 30%, 31%, a third. So we have like our cars, leading greenhouse gases, but the food system is actually contributing to greenhouse gases. And so again, we can talk more about this, but I want to set the stage. Healthcare often spends a lot of energy greening its health systems, right? Less reusables, or capturing all the gases in the anesthesia room, in the operating room, so it doesn't go into the atmosphere. And that's all important work, different technologies for lighting, all of that. That's 5%, 5% of greenhouse gases. Imagine healthcare awakening and trying to now use some of its might, its reimbursement pathways to tackle food systems, to demand food being grown in a particular way that reduces greenhouse gases. So that's the opportunity.
We have a few questions. Do you want those now or at the end?
Why don't we integrate some now and go?
Okay. So there was a question, is that from meat? Was the first one. You're 31%, I think.
Yeah, it's a combination because methane is produced from some of our beef, if you will, and meat producing.
And then the second question, does the 31% include the transportation?
This is farmed within the farm. So from production emissions from the farm to the farm gate, it's not beyond.
Okay,
So
those were the
transportation is kind of its own thing. Okay, great. And please feel free. I can't see the questions, so kind of alert me when they are coming in. I want to just talk about, this is where I'm going to talk about farming, and I'm not a farmer. My grandfather was a farmer, and he had a third grade education, and he was like the smartest guy in the whole town. But I'm not a farmer, but I've learned a lot about farming and kind of the story, especially with our partnerships. A lot of American agriculture is large industrial farms. There's a whole racialized labor exploitation. We have a whole history of that with the Bracero program, with our Mexican American community, our Mexican community. There's lots of exploitation that happens in our farming communities. We often do monocropping with one type of crop, like this is an example, with not a lot of different crops. We do tillage. Tillage, this is when you see the rotors, or things like breaking up the soil with a plow. We do add that at scale, and that destroys the soil. It increases greenhouse gases because you're emitting from all the microbes from below. This is it often uses fossil fuel intensive chemicals like pesticides, which we know have impact on our farm workers and surrounding communities. Chemical fertilizers as well, that all that nitrogen, it leads to waterway pollution and more greenhouse gases. So this is the farming piece, just a little clarity as to how this is impacting our ecological health. This is a complicated slide, but it gets to some of the questions, right? So this is from the Congressional Research Service. We have livestock farming and crop farming, and there's 3 types of gases that are emitted: methane, CH4, nitrous oxide, N2O, carbon dioxide. That's what most people think of, right, for global greenhouse gases, carbon dioxide. And then we have our fuel from the tractors and electricity, right? So there's a lot of things happening. I'll come back to this slide, but the way we farm, the way we grow our food has a direct contribution up to 31%. Just as a visual, soil is a big deal. 95% of our food is grown on healthy topsoil, and some predictions say 90% of the world's topsoil will be gone in 30 years. So how are we going to grow our food? Waterway. You can see this fish here, all that algae blooms. Agricultural runoff, right? We put all of this nitrogen fertilizer. It runs off and goes into our waterways and leads to over enrichment. It's called eutrophication, which means that a lot of algae is growing. The water is contaminated. You can't really swim in this. Dead zones, contaminated fish, right? So it has an impact directly on us as humans. So that's the ecological health part. And now it's like, okay, wow, Stephen, you really kind of laid it out and it sounds like we're never going to come out of this. And so what are we going to do about it? And what can we in healthcare do about it? So I'm going to share with you what we're doing about it in Alameda County. And I know that in San Diego, there are probably people on this call that are doing similar work. So I'm just giving you an example of what we're doing, and it's called Recipe4Health. And when I describe Recipe4Health to patients as well as to clinicians, I say it's food and health coaching. It's food and health coaching to treat, prevent, and reverse chronic conditions and to address food and nutrition insecurity. So treatment, prevention, and reversing chronic conditions, the patients that come to me in clinic, downstream care. And we're also kind of moving upstream to address food and nutrition insecurity. The food is not just any food. And this is, I think, what makes us unique in the country. I mean, not only us, there are other programs that are doing this type of work. I think the work that you guys have in San Diego with food pharmacies that you all are creating, with Food Shed is doing similar work. We are sourcing all of our food or we're putting all our food in produce boxes. All the food is local, organic, regenerative, BIPOC-led farms. We also combine that when it's appropriate with health coaching. This is a clinic that back in my early days, we built a brand new clinic, 36 exam rooms. We had 4 group rooms with clinic, a teaching kitchen. And this is a group of patients with a nutritionist. They're all sitting in group learning from health coaches, Move, Nourish, Connect, Be. So that's kind of our one-liner of like who we are. And then I'm going to show you who we are. But that's the kind of basic recipe for health. Seems kind of basic. It's not easy to do, but it's basic. And then I really want to center the question of where does the food come from for food as medicine? And then why does this matter? Most food as medicine programs are not thinking about where the food comes from because sometimes we in medicine, we just say, hey, any vegetable is better than a Twinkie or than or some, I don't know, some candy bar, right? It's like, yeah, of course. Does it really matter? Why does it matter? And so I want to answer that with hopefully through this presentation. And that's why I talked about the health multiplier at the top of the hour. We see Recipe4Health as a health multiplier. And I'll share with you what I mean by that. It's because we ask this question, where does the food come from? And we answer it in the following way. All of our food for our patients is sourced locally within 250 miles of Alameda County. It's all organic and or regenerative. And we get as many BIPOC-owned BIPOC-owned farms into our supply chain. By doing that, we develop co-benefits. And I'm going to be a bit nerdy here and call it H cubed E. H cubed E, because there's 3 H's and an E. The benefits are to human health, certainly for our patients, but also for the farm workers. You ripple it out. Also for the community with less pesticide drift. We also get economic health, opportunities for farmers. Our farmers are very small margins. Nobody's going into farming. Yet we need farming to create the food that we all eat. Economic health and benefits to the health system, and then also to the patient. Ecological health, soil and climate health in particular. Those are the 3 H's. So where does the E come from? It's equity. I know that's not a common word that people like to use nowadays, but we've used it from the beginning, and that's just who we are. We see all of this through the lens of health equity and racial equity to ensure that all communities benefit and that we're centering and prioritizing communities that have often been left behind. Now, why do we do this? Because if food as medicine does not create the guardrails for equity, we will run into a problem where it is an economic race to the bottom. We think by naming this up front, that if food as medicine programs, health plans, everyone looks at this and says, it's important to understand where our food comes from and to structure our incentives so that we can create this type of food. And farmers will tell me, if you will pay this, I will grow this way. But I need you to commit that you will pay this type of for this type of production, and then we can shift. But this is what that my kids get in school for free breakfast. Frosted cornflakes, muffins, bars. Now, again, if you're hungry, anything's better than nothing. But if this is what my kids get in school and they're eating this every day, they're going to end up in our clinic with fatty liver, prediabetes, all of the other markers of an unhealthy metabolic health system. So I think it's imperative that food as medicine programs think about where does the food come from and try to prioritize this way. Now, I'm going to give you now a view into how we did this. And like any recipe, there's ingredients, and we have 5 ingredients to scale this work. We start this work within the safety net health centers. This is not food systems trying to figure out how to work with health center or get into healthcare. This is health centers owning their role, learning how to use food as medicine, integrating and bringing in food partners in ways that health centers, doctors, nurses, nurse practitioners, nurses, et cetera, can think and use in the clinic. We combine that with a food pharmacy. Notice how we spell pharmacy. We combine that with a behavioral pharmacy, and I'm going to go through each of these. And then we fund this, right? You got to be able to fund it, and we use braided funding, county, Medicaid, USDA, philanthropy. The secret ingredient is the training and administrative hub. That's what our role at the county is. We have a team that coordinates, that does all the hard lifting, or all the hard work and the heavy lifting for our health centers. So they can just focus on taking care of the patients. The farmers can focus on growing the food and get paid. The health coaches can coach, and I should have said this is a health coaching team. Health coaches can coach, and the Medicaid folks make sure the Medi-Cal folks get all of their regulatory pieces met. I'm going to now go through each of the 5 ingredients to give you a view of how we're doing it. We're in Alameda County. Alameda County, north of you all, 800 square miles, the size of Rhode Island, about 1.65 million residents, 57 languages spoken. We have 21 clinics now across 5 safety net centers, from the Lifelong, Native American to Bercio Vasquez, Alameda Health System, Bay Area Community Health. Now, that's just us. Across the nation, there's 1,400 FQHCs with 19,000 sites. We're here. You guys are down here, right? Maybe you're already doing it too. But there's an opportunity for health centers to step into this work. Our second ingredient is a food pharmacy. It's a network of farms and a food hub. So we have over 45 local farms that produce the food, and then that is collected through aggregated through Farm Fresh to You, and then distributed. We are paying living wages to our BIPOC farmers as pharmacists. We are using only local, organic, and regenerative. This is a box, a nutrient-dense, delicious box of produce coming to your home. And I want to name this. We are providing that last mile solution, discreet weekly doorstep delivery. This is particularly very important now because many of our patients are fearful of going to public spaces like food banks or pantries or anywhere outside of their home because of ICE and CBP. So this infrastructure that we built many years ago, now others are throughout the county are beginning to say, hey, can you also start delivering the food to our clients in public health? So we're beginning to rev up and prepare for that because we know there's a lot of challenges in our community right now due to the federal government. This is an example. This is Tony. I was just at his farm 2 days ago. Tony Serrano, Mexican-American man, runs Jazz Family Farms, regenerative, organic certified, fair trade certified, 406 acres. This is just one example of one of the farms. Our third ingredient is a behavioral pharmacy with group health coaching. And the idea is that we partner with Open Source Wellness. They do group health coaching. They provide certified health coaches to our clinics. They help us run our group medical visits. I see sometimes I averaged 18 patients in a half day when I was seeing patients in the group and enjoying it way more than seeing 9 patients in a half day in regular clinic or 10. in the group were moving together, and I was just at the clinic and we just did this. We had a team from Japan visiting, and so we were showing them how it worked. It was a Spanish-speaking group, some of the Japanese spoke Spanish. It was fun. We're all dancing with the movement coach. We're talking about the food that just came and the recipes. We're connecting in small groups with the health coaches, and the health coaches then call you or text you and say, hey, Adrian, how are you doing on that goal you set? What are your barriers? How can I help you? Right? There's a weekly accountability structure. And then there's a mindfulness piece. So that's our third ingredient. Our fourth ingredient is the braided funding and policy work. And so we use county funding, we have philanthropy funding, we have USDA funding. We are pulling down Medicaid funding through these waivers and authorities. Our partners are Health Plan, Alameda Alliance for Health. It's a local managed care organization. The mechanism, this whole pathway is a mechanism which allows states to test new ways to deliver and pay for care, as long as the care is medically appropriate, cost effective, and addressing social drivers of health, like some of the work that we're doing. In the nation, 32 states are engaged in some type of policy work where they are using federal funding to the state to then pay for parts of food as medicine. Fifth ingredient is a training and administrative hub. This is really about expanding mindsets. I started at the beginning saying, hey, I'm a doctor. I'm going to be talking about stuff that's some people would say, hey, stay in your lane. And I'm like, well, health is in my lane and health can be expanded in many spaces. We have a whole training program, training clinicians in FQHCs. There's busy FQHC clinicians. We train them on how to use food as medicine in a 15-minute visit. I trained at Stanford many years ago. I got zero training on how to use food as medicine in a clinical visit. I trained at UCSF or in residency, zero training. When I did my fellowship in integrative medicine, I started getting some training. Now I'm a doctor, right? That's just where things are back then. But even now, when I talk to young physicians, they too are not getting much training. Our nutritionists get a lot of training, but there's not a lot of nutritionists. We have one clinic that has one nutritionist across one health center across their 18 clinics. They have only one nutritionist, right? So we need to elevate the game of all people who are interacting with our patients. That's our supposition. Nutritionists are there. Let's increase the number and let's get everybody trained up to understand how do you use food as medicine to treat, prevent, and reverse chronic conditions. We're also training the medical assistants on screening for food insecurity in a culturally humble way. We're also building into workflows in the electronic health record enrollment into SNAP for those patients that can and are willing. And then my team, this is the whole training administrative hub, we do the back end, the dirty work, if you will, the stuff that's unseen, but that you need to have ready and easily done so that your clinicians can click the right buttons. We do the electronic health record build. We do the workflow integration. We manage the whole Medicaid referral authorization claiming pathway so that our doctors don't have to fill out prior authorizations to justify getting food to their patients for diabetes or depression. Just some numbers, 21 clinics. We've had 64 trainings, over 975 attendees, clinicians and staff. When we ask the question, would you recommend this training to your colleagues? 95% say yes. Just trained 3 clinics last week. We have another one coming up in a week, and then another one in a few more weeks. These are our virtual trainings. We also do some in person, but a lot of it is all virtual, and we have a whole approach to doing it. So I'm going to close with impact. Like, okay, cool idea, Dr. Chen. Like, is it working? Like, you have this nerdy HQD thing. Is there truly any benefit? And could be a whole hour lecture in itself. So I'm going to try to give you the highlights here on these dimensions. From a human health reach perspective, and this is outdated right now, we have to update it, but 9,400 enrollees, 120,000 produce boxes. Again, we're delivering these produce boxes to people's homes as part of the prescription. It's 12 weeks 12 weeks of boxes, and you can renew if medically appropriate. 2.2 million servings of fruit and vegetables, and these are distributed throughout households, through doorstep delivery every week. I'm going to give you an example. This is Tammy. She says, My doctor told me about food as medicine. The first group gave me hope. It literally saved my life. It gave me my spark back. I started to care about myself and about others. Before I was overweight, my blood pressure was sky high. I had stomach problems. All of that is cleared up. I'm walking, I'm doing the online Zumba classes. That's our, we're doing this online as well as in clinic, the health coaching. My blood pressure is within normal range and I'm working to get off my medication. I've lost 77 pounds and I'm still going strong. Now, everyone loves the idea of, like she's very focused on all these areas and the weight. I just want to name one cautionary piece. Weight to me is not the end target. Obesity is not the end target in my mind. It's metabolic health. And metabolic health includes weight, but it's not the only thing. It includes blood pressure, it includes your sugar metabolism, it includes your cholesterol management. If we can really focus on metabolic health, the weight will come off or it won't. It doesn't matter as long as we can improve the metabolic health because we're all shaped differently. And I worry that sometimes people think, oh, Dr. Chen looks thin, therefore he's healthy. And if Dr. Chen was heavier set, maybe he's unhealthy. That is missing the underlying pattern here because it's all about metabolism and metabolic health and inflammation. You can't look at me right now and say if my liver is fatty. And fatty liver is going to be a lot more dangerous than if I have extra weight on my hips or my belly or whatnot, although sometimes they're correlated, but sometimes they're not. There are a lot more thin people who are sick metabolically than people necessarily than quote who are obese. So just a cautionary tale because I think everyone gets excited and she's excited. I totally support that. But I want us to be mindful as clinicians to not fat shame, and create a culture that we all have to look a particular way. The human health benefits, one slide just to show we're increasing the fruit and vegetable intake by about 0.8 servings. If you all put your fist up, everyone put their fists up on the screen. That's about one serving, roughly, of vegetables. We can get a little more precise about it, but I use that in clinic. One serving a day increase is a 5% reduction in death. If you do 5 servings, that's a 25% reduction. That's why we get to the 5 a day. So this is about almost one serving increase just by participating. That's a 5% reduction in death. Increased physical activity by 42 minutes. This is all COVID data during COVID time. So imagine those days when we were in COVID, we were all sitting on our computers, we weren't moving. Our patients were getting more activity by participating in the group. We saw a connection between mental health and food as medicine. 44% of our patients reduced their depressive symptoms on the PHQ-9. It's a scoring thing that we use in clinic. 32% reduced their anxiety symptoms, and that was scored on the GAD-7. Chronic conditions, a third of our patients with prediabetes and diabetes had a meaningful decrease in their A1C. It's a biomarker in the blood. And 2/3 of the patients showed at least a 10% improvement in their overall cholesterol pattern to prevent heart attacks and strokes. We certainly improved food security. 67% of our patients shared that they were more food secure now after the treatment compared to 43% before. And then reduced our healthcare costs. Our studies showed that this is validated by our partnership with Stanford. They looked at our data, 15% reduced likelihood of emergency room visits compared to control group. Economic health, just one slide. There's been studying to show that for every dollar spent at Recipe4Health, we're generating $1.9 for California. So if we spent $1 million, we're getting 1.9 million back. And then from remember I showed you the slide on climate and greenhouse gas. By the way of growing our food regeneratively and organically, we can reduce, not lose it all, but we can reduce these contributors to greenhouse gas. And we can also keep the soil covered and bring in more of the carbon dioxide from the environment into the soil and lead to more carbon sinkage. So we're taking some of that excess carbon dioxide in the air and putting it into the ground. From an equity, and then I'll close, and I think I've got time, this is perfect. 83% of our patients are BIPOC. You can see the distribution, over 51% speak Spanish. And that's just, I can keep on going on other pieces, but I'm going to close with just a call to join doing food as medicine with a regenerative twist. You don't have to do everything regenerative. We have chosen that. We want to encourage all people to move on the and the journey towards organic and regenerative local BIPOC. If you have any questions, you can feel free to reach out to me, and I am done at 36 minutes. So ready to take questions and have a conversation with you all.